Bom dia, bem-vindos à reunião geral online do Departamento de Psiquiatria do Hospital das Clínicas da Faculdade de Medicina da USP. Hoje nós temos dois convidados muito especiais para fazer essa palestra em inglês para vocês. O Dr. Scott Beach, diretor do Programa de Residência do Massachusetts General Hospital e do McLean Adult Psychiatry Residency, médico psiquiatra do Massachusetts General Hospital e assistente professor de psiquiatria da Harvard Medical School, falando com a gente direto de Boston, e o professor Bruno Caramelli, professor associado 3 da disciplina de Cardiologia da FMUSP e coordenador do Programa de Pós-Graduação em Ciências Médicas da FMUSP. Eles vão falar hoje um pouquinho sobre Qt Prolongation and Psychiatric Medications, então o prolongamento do Qt e as medicações psiquiátricas, e a gente espera que todos tenham uma ótima palestra, tá bom? Muito obrigada pela presença de todos e é um prazer tê-los aqui conosco. Professor Scott, you may start whenever you want.
Great. Thank you so much, Marita. Thank you for inviting me to be here and give this talk. I'm going to share my slides now. And so I'm going to talk today about Qt Prolongation and Psychiatric Medications. I want to start by just noting that some of the slides that I'm going to be presenting are slides that were developed in conjunction with some of my colleagues, including Dr. Margot Funk, Chris Solano, and Jolene Bostwick, and we have presented these slides at various meetings in the past. So what I'm hoping to do today is to first start by talking a little bit about what we mean by Qt prolongation, how to measure the Qt interval, and why we get worried about Qt prolongation in general. And then I'm going to talk for most of the time, actually, about some specific medications that may be associated with prolongation of the Qt interval and an increased risk for torsade de poids. And I'm going to talk about some common drug interactions there as well. We'll then spend a little bit of time looking at the EKG itself and kind of correlating that with what's actually happening in the heart. And then we're going to end by talking through some high-yield strategies for managing patients who are at risk for Qt prolongation in various settings and kind of work together to come up with a comprehensive risk-benefit analysis to help make clinical decisions. So when we think about Qt prolongation, the reason that we get concerned about it is because it is considered a risk factor for torsade de poids. And torsade is a malignant polymorphic ventricular tachycardia that can be associated with sudden cardiac death. So it can be lethal. Other symptoms of torsade may include lightheadedness and syncope, and it sometimes presents as seizures, though it does not cause true seizures. The name refers to the pattern on the EKG, and it just means a twisting of points. And you can see in the illustration below that a typical torsade rhythm varies in amplitude, but seems to kind of turn around a single point. The incidence of torsade is really challenging to estimate because many cases of torsade are not recognized, and some may just result in sudden death and not be recognized as torsade specifically. But it's thought that in the United States, there are about 12,000 cases a year, and the overall risk for torsade is estimated to be somewhere between 1 in 12,000 to 1 in 120,000 patients, so a fairly broad range. But the morbidity and mortality is quite high. Up to a third of patients who have an episode of torsade will experience significant morbidity and mortality. So it's sort of a dreaded outcome. There are really two main setups for torsade. The first is a group of syndromes known as congenital long QT syndromes. These are genetic syndromes that are associated with a prolonged QT and often lead to sudden cardiac death. And then the second group is known as acquired long QT syndrome. And this is the group that we're going to be more concerned with, in which QT prolongation occurs under certain clinical conditions, particularly in the setting of medications and other risk factors. Thinking about medications and the risk for torsade, it's important to recognize that Qt prolongation is only a marker for torsade, and it's an inexact marker. So some patients will have very long Qt intervals and never develop torsade, and other patients will develop torsade at pretty short Qt intervals. And so we consider it to be a marker, but it's really hard to estimate who is actually going to develop torsade. It's also important to recognize that in the absence of other risk factors, torsade is rarely caused exclusively by medications. So in other words, if somebody is healthy and has no other risk factors for torsade, it's very unlikely that they will develop an arrhythmia just because they were given a medication that might prolong the QT. 96% of cases of drug-induced torsade have at least one other risk factor for torsade. If we think from a pathophysiologic standpoint and think for a minute about the mechanism of torsade, it's really related to the potassium channels, and particularly a potassium channel known as IKR, which is sometimes referred to as the delayed potassium rectifier current. When there are disruptions in potassium efflux during the repolarization of the ventricle, this can lead to a widening as well as a distortion of the T wave, and that will typically manifest as prolongation of the QT interval on the EKG. So medications that interact with this channel, this IKR channel, are the ones that we're concerned about when it comes to QT prolongation and torsade. There's another class of medications known as sodium channel blockers that can also widen the QRS interval, and the most classic example of those in psychiatry is the tricyclic antidepressants. But they don't tend to cause the same concern with regard to torsade unless there is underlying structural heart disease or they're taken in overdose. So it's a little bit of a different mechanism with those medications. There are a number of other risk factors for torsade, and I want to spend a little bit of time on this slide because I think it's really important for psychiatrists to understand which of their patients may be at increased risk for torsade. Female sex is considered a risk factor. It's thought to be particularly between puberty and menopause, and it may be hormonally related. It does not seem to be the case in younger children, and it does not seem to be as much the case in older adults. But certainly between puberty and menopause, being female conveys an increased risk for torsade. There's also a correlation between age and the risk for torsade, and so a good rule of thumb is that the older somebody is, the more likely they are to develop torsade, or the greater their risk is for torsade. There's also, on the right side, a number of medical conditions that convey a risk for torsade, and so another good rule that I like to think of is the sicker somebody is, the more at risk they are for torsade. And you can think about that in a few different ways. You can think about the number of active medical conditions. If somebody has more medical problems, then they're at greater risk for torsade. But you can also think about that in terms of the environment in which you're seeing them. So if you're seeing somebody in the intensive care unit, that person is likely at a significantly higher risk for torsade than somebody that you're seeing in your outpatient clinic. Anybody who has a personal or a family history of drug-induced QT prolongation is also at greater risk for torsade, and anybody with a family history of sudden cardiac death should be considered to be at increased risk. In terms of modifiable risk factors, again, a couple of these to pick out for psychiatrists to be aware of. Probably the single most important modifiable risk factor for torsade is bradycardia. And that's a really important one to recognize. So patients who are bradycardic are at much higher risk for torsade than patients who are tachycardic. And we'll come back to this because one of the situations in which we're usually the most anxious about giving medications for fear of not causing torsade is in the intensive care unit when we have somebody who's really agitated and we're thinking about whether to give them an antipsychotic. And certainly you want to be careful about that, and we'll talk more about that situation. But it's also important to recognize that if somebody's really agitated, they're usually going to be tachycardic, and actually that tachycardia may be a little bit protective in terms of their risk for torsade. The other modifiable risk factor that's important to point out is that electrolyte disturbances also convey a significant risk for torsade, and specifically low potassium, low magnesium, and low calcium are considered important risk factors. So on our consultation service, whenever we're recommending a medication that has the potential to prolong the QT interval, we always leave specific instructions for the primary team to check the potassium and the magnesium every day and to replete those to the recommended levels of 2 and 4. And so that's an important recommendation to kind of mitigate against the risk for torsade. And then we'll talk about the fact that medications can prolong the QT and increase the risk for torsade. It's also important to recognize that pharmacokinetic drug-drug interactions are important. So if you have a medication that conveys risk for torsade and you have another medication on board that's going to increase the amount of that first medication in the system, then you want to be especially careful in terms of the risk for torsade. This is a graph just illustrating that the QT interval is heart rate dependent. And so as the heart rate increases, the QT interval actually shortens. And that is the reason why we have to correct the QT interval for heart rate and use that QTc to really accurately estimate the risk. There are several different formulas that have been developed to correct the QT for heart rate. And it's really important to know which formula you're using and what the advantages and disadvantages of that formula might be. So by far the most common formula that's used is known as the Bazette formula. It's a square root formula, and this is the formula that's used on almost every EKG machine. And so most EKG machines are standardized to use the Bazette's formula. Some of them may have the option for you to manually change and use a different formula, but they're usually standardized for Bazette. And it's also important to know that almost every study that has ever been done on QT prolongation and torsade has used the Bazette formula. And we'll talk more about some of the challenges of the Bazette formula. Another formula to be aware of is the Ferturisia formula, and this is a cubed root rather than a square root formula. And then there are a series of linear correction formulas, and one of the ones that was developed in the US is known as the Framingham Formula. And I would highlight the fact that the American Heart Association for the last decade has actually recommended using a linear correction formula rather than the Bazette. So that's actually the recommendation, is to use a linear formula to correct for heart rate. However, in practice, very few people actually use a linear formula. And finally, a formula that I really like is a linear formula that's known as the Hodges Correction. And this is the only formula that allows you to use the heart rate directly rather than calculating or using the RR interval. And so this is the formula that we teach our residents and fellows to use as kind of a first pass correction, because it's easy to do very quickly. And you just use the QT either manually measured or the QT given to you by the EKG, and then you incorporate the heart rate, and that'll give you a valid correction for the heart rate. Another formula or concept that has been developed in terms of correcting for heart rate is something that's known as the Qt Nomogram. So this is similar to nomograms that you may be familiar with in the setting of acetaminophen overdose, for example. And the idea is that it plots QT interval against heart rate, and anything that falls above that line suggests an increased risk for Torsade. Anything that falls below that line is considered okay or sort of within normal limits. So thinking about the Bazette formula specifically, it's important to recognize that the Bazette correction tends to overcorrect at higher heart rates, and it tends to undercorrect at lower heart rates. So Bazette is an excellent formula to use when the heart rate is approximately 60 beats per minute. But if you have someone who's really tachycardic and their heart rate is in the hundreds, and you correct using the Bazette correction, you're going to get a much higher QTC than may actually be the case. And you're going to be more worried about that patient than you may need to be in terms of their risk for Torsade. And similarly, if you use the Bazette formula for somebody who's really significantly bradycardic, you're going to get a much lower QTC than may actually be the case, and you may be falsely reassured in that situation. So it's important to recognize that Bazette becomes pretty flawed as the heart rate gets significantly away from 60 beats per minute. And when you plot the Bazette formula against the other formulas, you actually see that it doesn't really line up well with the other formulas. So this is a graph from a study known as the Penn Atrial Fibrillation study that looked at different methods of correction. And you can see that Ferturisia, Framingham, and Hodges kind of grouped together. And Bazette, which is shown here in red, is a little offset. You'll notice that Bazette tends to give you the highest QTCs. So again, it tends to sort of overcorrect. And you'll also notice that Bazette has a really wide range, whereas the others are a little bit narrower. Bazette's is quite wide in terms of the range of values. This is another graph just sort of illustrating that and demonstrating that as you get into higher heart rates, the Bazette formula, which is the one that sort of goes highest on the graph, really deviates significantly from the other correction formulas, which tend to group together. So again, in our service, we really try to avoid Bazette correction a lot of the time. If we have EKG machines or we're using EKG machines that rely on Bazette formula, then we will typically correct the QTC on our own, generally using a linear correction formula to do that. Normal QT ranges have been the subject of much debate. And I would highlight a few take-home points from this slide. The first of which is that, in general, men have shorter QT intervals than women do. So the normal for men is considered below 430 milliseconds. The normal for women is considered below 450 milliseconds. There's then a middle range where things are sort of borderline concern. And then prolonged QT intervals for men are considered to be greater than 450 milliseconds, and prolonged QT intervals for women are considered to be greater than 470 milliseconds. Again, there's debate, and there's also debate about when we as clinicians should be concerned. Some people say that any QTC greater than 450 milliseconds should raise concern. We tend to think of 500 as the number at which we start to get a little bit concerned or cautious, but there's not really a great way to sort of pin that down because there's so much individual variation. As a general rule, though, the risk of ventricular arrhythmias is said to increase by 1.052 raised to the x power, where x is every 10 milliseconds above a QTC of 400 milliseconds. So that's pretty confusing, but basically this formula was derived as a way to estimate the relative risk of Torsade or a ventricular arrhythmia based on the QTc. And if you plot this out, you will find that at a QTc of 450 milliseconds, that means that somebody has a relative risk of 1.29 relative to a QT of 400 milliseconds. And so they have a 1.29-fold increased risk of ventricular arrhythmias compared to a person with a QTc of 400 milliseconds. If you extrapolate that further, you'll find that at a QTc of about 550 milliseconds, the risk is about 2.5-fold. And if you go back to the base rate of Torsade, you may remember that we estimated that at 1 in 12,000 to 1 in 120,000. So even at a QTc of 550 milliseconds, which many of us would consider quite concerning, the absolute risk of Torsade remains quite low because it is a low frequency event. And that's important to put in perspective as well. All right, so we're going to switch gears now, and we're going to talk about some specific medications that may convey a risk for QT prolongation or Torsade. We're going to talk about a few different classes of medications, but we're going to start with antipsychotics. Before we get there, I do want to just talk a little bit about some of the limitations of the available data. Again, it's important to recognize that most studies that have been done used Bizet's formula to correct the QT, and so that introduces an inherent challenge in terms of interpreting the data. The timing of measurement also varies a lot in the studies, and there is debate about whether you should measure at peak dose, you should measure at steady state, and so that's an important consideration. Other risk factors that the patient may have had are often not well controlled for in the studies, as well as other medications that they may have been taking. It's also important to recognize that we don't really have a great sense of what a clinically meaningful QT prolongation is. We generally use 20 milliseconds as a cutoff, but that is, to some extent, somewhat arbitrary. And then the last thing I'll just mention is there is a website that is run by somebody in the United States called Credible Meds. I don't know if that's widely used in Brazil, but it is pretty widely used in the US. And the idea is that Credible Meds is a quick reference that groups different medications into different categories of risk for Torsade. It's useful to see if a medication has any association with Torsade, but my concern with Credible Meds is that it tends to lump together medications that are actually very different in terms of what the data suggests as the risk. And as an example, in the category of highest risk, it includes some medications like donepezil that really only have a couple of case reports linking them to QT prolongation. And so it's hard to get a sense from that resource as to whether a medication is actually of significant risk. All right, so if we think about antipsychotics, we've known that antipsychotics have the potential to be associated with QT prolongation and Torsade for a very long time, since the 70s and 80s, and that was the case with the typical antipsychotics. Low-potency phenothiazines, so medications like thioridazine, chlorpromazine, mesoridazine, are the class of antipsychotics that are most associated with QT prolongation. They're also overrepresented in cases of sudden cardiac death. Of all antipsychotics, thioridazine causes the greatest amount of QT prolongation, on average about 30 milliseconds. And this has led in the United States to thioridazine being really rarely used. It's still available, but it's almost never used because of that risk. And it is thought that for the low potency phenothiazines, the risk of QT prolongation does appear to be dose dependent. As an entire group, the first generation or typical antipsychotics lead to modest QT prolongation compared to placebo, so only about 5 milliseconds, and this effect is primarily driven by phenothiazines. Among other typical antipsychotics, pimozide, fluphenazine, droperidol, and loxapine have also been associated with QT prolongation. Haloperidol has also been associated with QT prolongation. And in the United States, if you were to ask a cardiologist or an internist what medication carries the most risk of QT prolongation, you would most likely hear haloperidol as the response. So this is a topic that I got really interested in because we use a lot of haloperidol on the consult service. And so we wanted to kind of investigate whether this is actually true with regards to haloperidol or whether the concern has been overblown. And it turns out that there's a recent meta-analysis which found that the effects of oral haloperidol on the QT are similar to several atypical agents, including olanzapine and quetiapine, and that the risk of oral haloperidol causing QT prolongation has probably been significantly over-exaggerated. Even for IM haloperidol, most studies show a QT prolongation of only about 5 to 8 milliseconds, which is less than the case for most second-generation antipsychotics and unlikely to be clinically significant. It is important to recognize that there are some studies that do suggest a greater risk for ventricular arrhythmias or sudden cardiac death with oral haloperidol. So compared to olanzapine, haloperidol in one study conveyed a 1.72-fold increased risk of sudden death or ventricular arrhythmia. But neither of these studies controlled for other risk factors. So it's a little bit unclear about the risk for ventricular arrhythmias or sudden cardiac death with haloperidol. We also wanted to pay particular attention to intravenous haloperidol because on our psychiatry consultation service, that's really the primary medication that we use to help manage patients who are delirious. And so our group recently completed a systematic review looking at intravenous haloperidol and QT prolongation or Torsade. There's a lot of literature on this, and in the United States, in 2007, the Food and Drug Administration actually issued a pretty significant warning for IV haloperidol that suggested increased risk and actually recommended continuous telemetry for any patients on IV haloperidol. So in the US, if you're following the FDA recommendation, if somebody is getting even 1 milligram of intravenous haloperidol, they actually should be on continuous EKG monitoring. This is rarely done in practice, but that's actually the official recommendation based on this warning. In 2010, there was a systematic review of case reports that was done, and that determined that 97% of the case reports of QT prolongation or Torsade involving intravenous haloperidol had at least one other risk factor present. And of those 70 cases, only one of them resulted in death. In our meta-analysis, we focused on more recent literature, and we discovered that 10 out of 11 recent prospective studies involving a total of 1,500 patients and on doses of up to 20 milligrams found no evidence of QT prolongation with intravenous haloperidol. We also noted that there's actually no study that has ever been done to show that intravenous haloperidol causes more QT prolongation than other forms of haloperidol, even though that's a common myth. So it's commonly said that IV haloperidol carries much greater risk for QT prolongation and Torsade than oral or intramuscular haloperidol. That's actually never been proven. And there's really no clear evidence to suggest that intravenous haloperidol causes a greater amount of QT prolongation than any second-generation antipsychotics. The one study that did seem to suggest that failed to control for indication, and so patients who received intravenous haloperidol were likely sicker and probably more likely to have delirium as opposed to schizophrenia or other conditions. So based on our systematic review, we came up with a series of new recommendations for the use of intravenous haloperidol. Important among these, we recommend that the Bazette formula not be used to correct the QT, but that a linear correction formula be used. And it's actually been demonstrated in another study that using the QT Framingham of 480 milliseconds, or even an uncorrected QT of 436 milliseconds, are actually better predictors of torsade in patients treated with IV Haldol than using a cutoff that's based on Bazet formula. So our recommendations recommend actually no EKG monitoring if the total dose of IV haloperidol is less than 5 milligrams daily and there are fewer than 2 other risk factors present. In situations where the total daily dose is greater than 5 milligrams daily, or there are 2 or more risk factors, we do think it makes sense to check a baseline EKG as long as it's a non-emergency, and at least 1 follow-up EKG, preferably 30 to 60 minutes after administration. But we would only consider a daily EKG for total cumulative doses of greater than 25 milligrams. And this is an important recommendation because right now I would say the most common practice in hospitals for patients who are on IV haloperidol is for them to get daily EKGs. And so in the review that we did, we found that the evidence for that really only exists for higher doses of haloperidol. And then we made a recommendation that continuous monitoring or telemetry or consideration of alternative agents is really only necessary if the QTc corrected properly is greater than 500 milliseconds, or if you're using a very large total dose like greater than 100 milligrams. We also would highlight that there's, again, minimal evidence to suggest that switching to another antipsychotic is safer. And so we often hear from our colleagues in medicine and cardiology, I'm really concerned about this patient in terms of their QTc or in terms of torsade. I don't think we should use IV haloperidol. I think we should use olanzapine instead. And there's really no evidence to support the idea that olanzapine is safer in that regard. When we think about atypical antipsychotics or second-generation antipsychotics, it turns out that most second-generation antipsychotics do cause some degree of QT prolongation, and this is evident from a systematic review and network meta-analysis that was done in 2019 using placebo-controlled or head-to-head trials. Of the atypical or second-generation antipsychotics, it's pretty clear now that ziprasidone causes the most QT prolongation. In 2002, the Food and Drug Administration issued a specific warning for ziprasidone because of its increased risk for QT prolongation. And the average QT prolongation with ziprasidone is estimated to be somewhere between 10 and 20 milliseconds, but 20% of patients using ziprasidone will experience an increase of greater than 60 milliseconds, which has the potential to be clinically significant. In a meta-analysis in 2019 that looked at all of the atypical second-generation antipsychotics and sort of ranked them by propensity to cause QT prolongation, ziprasidone performed the worst. Quetiapine is another agent that has some association with QT prolongation. In 2011, we actually got a strengthened warning regarding quetiapine. And this warning, which is currently in place, recommends avoiding the use of quetiapine with other QT prolonging agents and avoiding the use of quetiapine in any patients with a history of arrhythmias or with metabolic deficits. I will say most practitioners are not aware of this warning and think of quetiapine as similar to other antipsychotics and not conveying any significant risk. And it's interesting that quetiapine has been singled out in this way because the overall evidence doesn't really suggest that it's much different from other second-generation antipsychotics. It was based on 12 case reports, but most of those were in the setting of overdose or in combination with other agents known to prolong the QT interval. Overall, the data is mixed. Most studies suggest mild effects, but there is some evidence that a percentage of people may experience more clinically significant QT prolongation. And quetiapine has also been associated with an increased risk of out-of-hospital cardiac arrest. And so there may be some increased risk there, even independent of QT prolongation. Thinking about other second-generation antipsychotics, aripiprazole and lurasidone are thought to be the best from this standpoint, meaning they cause the least amount of QT prolongation and torsade. And olanzapine, risperidone, and clozapine are likely similar to one another and probably somewhere in the middle. So when we think about prescribing antipsychotics in the setting of QT risk, we can risk stratify them to some extent, though it's really hard to do. It's really hard to say this agent is a greater risk than this other agent, but we can put them into broad categories. And so agents with low risk include aripiprazole and lurasidone. Agents with middle or moderate risk include haloperidol, olanzapine, risperidone, clozapine, and quetiapine. And agents with high risk include ziprasidone, thioridazine, and probably chlorpromazine as well. There's also mixed data about whether the use of multiple antipsychotics together leads to greater QT prolongation. If it does, it probably has to do with relative cumulative dose rather than the mixing of different medications. So when we use antipsychotics in the outpatient setting, we don't recommend monitoring for patients who don't have other risk factors for QT prolongation unless you're prescribing an agent that is a very high risk, like thioridazine or ziprasidone. For patients with multiple risk factors, or for patients taking one of those high-risk agents, we generally recommend checking an EKG at baseline and then again when the medication reaches steady state. And for patients with multiple risk factors for whom you're prescribing a high-risk medication, so somebody who has a history of arrhythmias and you want to start them on ziprasidone, in that case, we would probably consider a cardiology consultation. I'm going to switch now and talk about antidepressant agents, and the risk with antidepressants and QT prolongation is a newer concern that really only came about in the past decade. And it really revolves around this story of the citalopram controversy. So in the United States, the controversy with citalopram really started in 2011 when the FDA, sort of out of the blue or out of nowhere, issued a warning for citalopram and suddenly said that citalopram should not be prescribed at doses greater than 40 milligrams and should not be prescribed at doses greater than 20 milligrams in those with liver dysfunction who are over the age of 60. And this was really surprising to psychiatrists because up until that point, citalopram was the most commonly used antidepressant in the United States. It had been the medication that was used in the STAR-D antidepressant trial, and so it enjoyed a lot of popularity based on that. And so this was a warning that really significantly changed clinical practice because citalopram was often used at doses greater than 40 milligrams. About 6 months after the initial recommendation, the FDA revised its warning and they changed the language a little bit. So instead of shouldn't be used, they said it's not recommended. And so they continued to urge caution, but they backed up a little bit in terms of the warning. Well, it turns out that all of this was really based on a single study that was done. And it's a type of study known as a thorough QT study. And that's really the gold standard kind of study for looking at the effects of a medication on the QT interval. And in that study, it was discovered that at doses of 20 milligrams, citalopram prolongs the QT interval by about 9 milliseconds. And at doses of 60 milligrams, it prolongs the QT interval by about 19 milliseconds. 40 milligrams of citalopram actually wasn't studied in that thorough QT study, but it was extrapolated that the QT prolongation would be about 13 milliseconds at 40 milligrams. What is unique about the warning that came out of this study is that it wasn't just based on the absolute QT prolongation. So 18.5 milliseconds actually doesn't reach the typical threshold of 20 milliseconds that the FDA had historically used. And instead, the warning was based on the FDA's assertion that 60 milligrams of citalopram is no more efficacious than 40 milligrams of citalopram. And so in other words, they said, we can't justify the increased risk that's associated with 60 milligrams because there's not evidence that 60 milligrams is better. And this was controversial because many psychiatrists would say that for some individual patients, it's pretty clear that 60 milligrams is better. The FDA also issued or ordered a similar study to be conducted with escitalopram that was set up nearly identically, which showed some QT prolongation, but of a smaller degree with escitalopram. And this didn't result in any recommendations in the United States about the use of escitalopram, though in the United Kingdom, they did issue a warning for escitalopram as well. Since then, there's been a lot of studies looking at citalopram and QT prolongation. A group at our hospital did a cross-sectional study of EKGs in 38,000 patients and found that citalopram was associated with a dose-dependent increase of similar magnitude to the FDA study. Our group conducted a systematic review and meta-analysis of 16 studies involving SSRI antidepressants as well as tricyclic antidepressants. And we found that both citalopram and escitalopram had statistically greater QT prolongation than placebo, and that citalopram separated out from all other antidepressant agents except for escitalopram rather. Other studies have found, again, that there does seem to be an increase in the QTC on the order of 10 to 20 milliseconds with citalopram. But the evidence with regards to Torsade is a lot less clear. So what we think is the case is that citalopram does cause some moderate QT prolongation, but when it comes to an association with Torsade, it's not clear at all. So a cohort study done in veteran administration hospitals involving almost 1 million patients found that citalopram doses of greater than 40 milligrams were actually associated with a lower risk of ventricular arrhythmia and all-cause mortality. And another study looking at data from Medicaid showed that high-dose citalopram does not differ from other agents in terms of sudden cardiac death. And so what we would conclude from all of this evidence is that citalopram probably does increase the QT interval by somewhere between 10 and 20 milliseconds, but that the actual risk of Torsade or sudden cardiac death associated with that increase is probably not clinically significant. It's also really important to keep in mind that prescribing lower doses of citalopram also has risks associated with it. So as a result of those warnings in the United States, within 2 years, over half of patients who had been on doses higher than 40 milligrams were put on doses of 40 milligrams or less. So again, it really did impact prescribing practices. At the same time, there were also increased prescriptions for interacting medications, as well as for sedative hypnotics like benzodiazepines. And EKG monitoring actually didn't change at all over time. So people weren't more cautious about monitoring, but they were more cautious about prescribing. And older adults in particular were less likely to have their doses reduced. So those guidelines about using less than 20 milligrams in older adults, those weren't followed very closely, but the general guidelines about using less than 40 milligrams were adhered to. Another study found that the reduction in citalopram doses may have led to increased rates of psychiatric hospitalization and increased rates of overall mortality. So this was showed in a study that when patients had their doses of citalopram reduced, their rates of hospitalization went up and their overall mortality increased, but their cardiac mortality did not seem to decrease. And so the downsides of this change may have significantly outweighed the benefits. In terms of escitalopram, as I mentioned, there was a similar pattern of dose-related QT lengthening in the study, but there's been no warning in the United States about escitalopram. It wasn't associated with greater mortality in a cohort of Medicaid patients. And there's a meta-analysis from 2013 that showed that with escitalopram, the mean QTc increase is probably only about 3.5 milliseconds, which is very unlikely to be clinically significant. And only one patient out of about 2,400 patients in that study had a QTc of greater than 500 milliseconds and a baseline change of greater than 60 milliseconds. So what we would consider clinically significant QT prolongation. So our take home with escitalopram is that it may carry some risk of mild QT prolongation, but it's unlikely to be clinically significant. If we think about other antidepressants, it appears that the other SSRIs should be considered largely safe. They have been well studied in cardiac populations, particularly sertraline. And although there are case reports for all of those agents linking them to QT prolongation or Torsade, and that's true for all SSRIs except paroxetine, the relative risk for the other SSRIs appears to be very low. So we would have no concerns about starting somebody on sertraline or fluoxetine, even if they had some risk for QT prolongation, and we generally recommend those agents as first-line antidepressants for patients who have cardiac problems. As I mentioned earlier, the tricyclics are a unique class because they're sodium channel blockers, and because of that, they generally pose danger at therapeutic doses only in patients with pre-existing bundle branch disease or ischemic heart disease. It's hard to tease apart which tricyclics may be worse in that regard, but there's a little bit of evidence suggesting that amitriptyline and meprodoline may be more commonly implicated in cases of Torsade. In terms of other antidepressants, I just would highlight venlafaxine as probably having the most evidence for QT prolongation of any antidepressant other than citalopram or escitalopram. But it's important to keep in mind that most of those cases have occurred in the setting of overdose or other risk factors. So if I was going to give an antidepressant to somebody who I thought was at moderate to high risk for QT prolongation or Torsade, I probably wouldn't choose venlafaxine as my first line treatment, but I also would not necessarily hesitate to give venlafaxine to a patient who might have other risk factors if I thought there was a compelling reason for using that agent specifically. Bupropion has been associated with QT prolongation in the setting of overdose, but that is almost certainly confounded by tachycardia and the use of Bazette formula to correct, and so we don't really worry about bupropion as being at high risk. Mirtazapine is another medication that has some controversy, and actually a lot of our cardiology colleagues have it in mind that mirtazapine may cause QT prolongation. The evidence doesn't really support that. In overdose in one study, no patients had clinically significant QT prolongation. And while there has been a study linking mirtazapine with an increased risk of sudden cardiac death, the authors in that study hesitated to make causal association because of other confounding factors. And another study actually showed a lower risk of cardiac events than with other antidepressants. So I don't worry much about mirtazapine, but it is one that you sometimes hear concern raised about. Other antidepressants, including a lot of the newer ones like duloxetine and vilazodone, really have not been associated with any significant QT prolongation. So overall, we think the use of antidepressants carries a low risk. And we don't really think there's an indication for a baseline EKG with all antidepressant initiation. We might consider a baseline EKG in somebody who has significant risk factors if you were starting them on an antidepressant, or if you were starting citalopram, then it might be reasonable to check a baseline EKG. Citalopram for us is no longer a first choice for patients with pre-existing heart disease who need an antidepressant. We would reach first for sertraline based on the concerns with citalopram. And I'll also just highlight that in 2018, guidelines were published in the Netherlands that do recommend EKG monitoring for patients with 2 or more risk factors being started on citalopram or escitalopram. These are really the only guidelines that I'm aware of that talk specifically about monitoring with citalopram or escitalopram. For patients who you do need to start citalopram and they have significant risk factors, that might be another time when you could consider a cardiology consult. But if there's one takeaway with regard to citalopram today, I would say it is to not reflexively reduce the dose of citalopram without a careful risk-benefit evaluation. So if a patient comes into your office and they have terrible OCD, and they've been treated with 60 milligrams of citalopram for decades, and that's worked really well for them, I would not automatically reduce their dose of citalopram to 40 milligrams just because you're concerned about a theoretical risk of QT prolongation at doses higher than 40 milligrams. Really quickly, I'm going to talk about some other classes of medications. So with regards to mood stabilizers, most mood stabilizers do not have any evidence for QT prolongation. In fact, valproate has been shown to lower QT dispersion, suggesting that it may have some protective effects. And there's no evidence of QT prolongation with medications like carbamazepine or oxcarbazepine, lamotrigine, or other medications that are used as mood stabilizers. In terms of lithium, there is a small suggestion that doses of lithium that lead to toxic lithium levels may convey a risk for QT prolongation. But generally, if patients have lithium levels within the therapeutic range, they don't appear to be at increased risk for prolonged QT. And so lithium is not a medication that I typically worry about in terms of QT prolongation or Torsade. Of course, lithium is associated with other cardiac effects and other arrhythmias, including sick sinus syndrome, but with regard to QT prolongation, it's typically not a concern. In terms of other psychiatric medications, stimulants can cause an increase, I think we all know, in heart rate and in blood pressure. And they have been associated with arrhythmias, particularly atrial arrhythmias, but there is no statistically or clinically significant QT prolongation with the use of methylphenidate or amphetamine drugs. So particularly thinking about Torsade, we don't really worry about stimulant medications, but of course they have other cardiac effects and they may have other associations with arrhythmias that are important to keep in mind. Atomoxetine is a medication that's sometimes used for stimulant-like properties. It has been associated with QT prolongation in some case reports, but each of those cases had other contributing variables, and a pooled analysis showed no clinically significant increase in QT prolongation. So like most of the antidepressants, we don't really worry about atomoxetine in terms of QT prolongation or Torsade. Modafinil is sometimes used for attention or stimulant-like effects. There's no evidence that it has effects on QT prolongation. And similarly, clonidine and guanfacine, which are sometimes used in children with attention deficit hyperactivity disorder, don't seem to have any significant effect on QT prolongation or risk for Torsade. So in patients who are being prescribed stimulants, there's no recommended monitoring with regard to QT prolongation, but of course, for the other risks associated with stimulants, you want to be cautious in patients with underlying heart disease or in patients with a history of arrhythmias. Trazodone, which is very commonly used for sleep, has a few case reports of QT prolongation in the setting of overdose. and it may cause a modest dose-dependent QT prolongation, even at therapeutic doses, but this is likely clinically insignificant, and we don't really worry about QT prolongation with trazodone. Benzodiazepines have no effect on the QT. They seem to be very safe in this regard. And interestingly, buspirone for a long time was considered totally safe, but there is now one study that suggests that it may have some increased risk for QT prolongation. Real quick on other agents, the other one I just want to highlight is donepezil, which is sometimes used for patients with dementia. As I mentioned earlier, it's classified by Credible Meds as being at high risk, but really it just has a couple of case reports, and all of those reports had other risk factors. So it's really unclear what the risk is with donepezil. I want to spend just a few minutes talking about opioids, and this is significant because of all medications, methadone is one that carries the greatest risk for QT prolongation and torsade. And so that's one that as psychiatrists we really need to be aware of. It's a potent inhibitor of delayed potassium rectifier currents. And in the United States, there's actually a black box warning, which is kind of the highest level of FDA warning about potential cases of QT prolongation and torsade during treatment with methadone. Because of this, there's now a recommendation that all patients engaged in methadone maintenance programs have a risk management plan. That includes a baseline EKG for any patient with other risk factors for QT prolongation, and an annual EKG for anybody whose methadone dose exceeds 120 milligrams daily. And then if patients are found to have QT prolongation, then there's a list of potential strategies, including reducing the dose, looking at other factors, or transitioning to a different agent. Buprenorphine seems to be a safer alternative to methadone from a cardiac standpoint. It has not been shown to prolong the QT or be associated with torsade. It does also block the delayed potassium rectifier channels, but is a much less potent inhibitor than is methadone, and so seems to be much safer from this standpoint. So thinking about non-psychiatric medications, it's also important to recognize that there are a lot of offenders in terms of other medications that psychiatrists don't typically prescribe. And there's been over 100 medications that have been shown to have the potential to prolong the QT or be associated with torsade. In the ICU, up to 30% of patients may receive medications that prolong QT, and 20% of patients are administered 2 or more of those agents. And even in outpatient, a quarter of prescriptions involve QT prolonging agents. So it's important for us as psychiatrists to make sure we have a complete medication list and to know what else our patients are taking, including over-the-counter medications. And here's just a list of some other common categories of QT prolongation agents that would be important to be on the lookout for in your patient's medication list. So in summary, medications are only one of several possible risk factors for QT prolongation. Co-administration of 2 or more medications is of particular concern. And as a general rule, it's good practice to avoid high-risk medications if lower-risk options are available, but you should always consider a careful risk-benefit analysis because things need to be individualized to the patient. In the last few minutes, I just want to talk briefly about cardiac electrophysiology and EKG interpretation and risk stratification. And I'm going to go through this part of the presentation relatively quickly. So in terms of what's actually happening in the heart, we've already talked about the fact that it's really the potassium channels and particularly the delayed potassium rectifier current that we worry the most about with regards to QT prolongation and torsade. As psychiatrists, I think it's important to think about when we might order an EKG. One thing that's important to keep in mind is that your EKG measurement should be current. And so it's not that helpful to use a baseline EKG that's a year old. You really want to get an EKG that's within a month of the decision that you're making. Anytime you make a substantial change to a medication that may convey risk for QT prolongation, it's good practice to at least think about getting an EKG. And anytime there's uncertainty about cardiac status, it's also helpful to think about getting an EKG. There's a lot of debate about who can interpret an EKG. We believe that all psychiatrists should be able to interpret basic EKGs. Of course, we have to rely on our colleagues in cardiology when things are more complex or when the EKG is unusual. But it's good practice as psychiatrists to at least be able to look at an EKG, to be able to hand calculate the QT and have some sense of what risk looks like with regards to the EKG. It's important to know in this regard that the QT varies from lead to lead. It's usually recommended that you measure in the lead with the longest QT, and that's usually either lead 2, V2, or V3. And there are many factors of the EKG that may make it challenging to interpret the QT, one of which is the presence of U waves, which may make it harder to see the T waves. When you're measuring the QT, the recommendation is to determine the beginning of the Q wave. So this is the QRS complex shown here. And then to draw a tangent at the steepest part of the T wave. And where that tangent intersects the isoelectric baseline, that's the end of your QT interval. And so your measurement should be from the beginning of the Q wave to the end of the T wave. There are a couple of situations that make it really challenging to measure the QT. One of those is atrial fibrillation because of the variability in RR intervals. There's really no good agreement about how to estimate the QT in cases of atrial fibrillation. Even cardiologists have a hard time with that. And so the general recommendation is that you either average multiple complexes, so you pick 5 or 6 different complexes on the EKG and average the QT in all of those, or that you find the longest and the shortest complex and you average the QT in those 2. The good news is that, again, because torsade is rare when patients are experiencing tachycardia, atrial fibrillation generally may actually convey some protection for torsade and is not considered a high-risk state. A widened QRS interval can also make it really challenging to determine the QT interval, and this can occur in the setting of a bundle branch block or in patients who have a pacemaker. It's challenging because the widening of the QRS actually doesn't affect repolarization, and so it doesn't actually increase the risk for torsade. And so there are 2 recommended approaches. One is to ignore the QT completely and use a totally separate measurement, which is known as the JT index. The other is to just correct for the wide QRS by subtracting 100 milliseconds, which is kind of the typical or the normal QRS width. And so you subtract 100 milliseconds from the widened QRS and then subtract that number from the QT as a way of deriving a more accurate QT, which you then can correct for heart rate. A summary of take-home recommendations with regard to EKG interpretation. Remember, Bazette has a lot of problems, so we recommend using a linear correction formula instead. Manual measurement is always recommended when it's feasible. Medications are only one of several possible risk factors for QT prolongation, and it's important to keep in mind that combinations of risk factors create cumulative risk, and so you have to be on the lookout for patients who have multiple risk factors, and co-administration of 2 or more QT prolonging medications is of particular concern. Guidelines and warnings obviously vary country to country, so it's important to recognize the guidelines where you're practicing. But in general, patients who are being treated with a medication that is known to prolong the QT interval or with a medication that has a regulatory warning, those are times when you want to think about whether there may be a safer alternative available. That being said, there is no absolute QT interval at which a psychotropic medication should not be used, and that's an important principle. So we've given intravenous haloperidol even to patients with QTCs of 550 milliseconds if the clinical situation warrants it, but it's really important to do an individual risk-benefit analysis in all of those cases. You also have to consider the risk of failure to control high-risk psychopathology and the risk of psychiatric decompensation. And I think these risks don't often get taken into account. We worry a lot about Torsade, we worry a lot about cardiac outcomes, but we don't always think about the other risks of somebody ripping out their central line if they're really delirious and agitated, or the risk of somebody experiencing a relapse in their depression, which has been stable for a decade, if their citalopram dose is reduced. In general, routine cardiology consultation is not indicated when prescribing medications that may have the potential to prolong the QT. But if you have a really high-risk case and you're unsure what to do, in that setting, cardiology input may be quite helpful. So I'm going to end there, and I'm really excited to hear the discussion from our discussants, and I'd be happy to take any questions as well. Thank you.
Thank you, Professor. So I'll open for Professor Bruno and Professor Ali to talk a little about their opinions and comments.
Your microphone, Bruno. Bruno, microphone. Bruno, your microphone.
Okay, sorry. Thank you, Scott. Thank you again, Euripides, for the kind invitation, and you, Marina, for your kind coordination of this session. I'm really excited with the comprehensive lecture that Scott did, and I could not expect so nice and comprehensive presentation based on the publications from Scott and his group. As is common here in Brazil, I have to declare my potential conflict of interest. And number one is, I should say, I hate IV haloperidol. I really hate. Please don't use. And maybe because this is another bias that I have, because I'm always called to act when there are complications, cardiovascular arrhythmias and complications related to IV haloperidol in the middle of the night. Please, I hate, don't use. Okay, I can further discuss another way with Marina's cookies, and but I don't like it. And my second potential conflict of interest is that I'm a cardiologist and I'm deeply involved with consultation in Brazil at our institute. And I have to tell you that everybody who was included in our hospital group, that you can ask a consultation through internet and email, cardiology consultation, and we will be there in 48 hours. We are deeply involved in a method to build an application, an app, to ask for these consultations regarding the use of arrhythmias with other, not only psychiatry, but other drugs to be used, and to ask for and to answer for requests for other specialties. I have to add some comments, small comments regarding Scott's presentation. And one, I think, important thing is generally psychiatrists and other specialties ask what is the frequency of, Scott told us when to order the EKG, and that's important that the other physicians know how to interpret the QT interval. There are several, like MedCalc is the most popular one, app that can help us to calculate QT interval, even in the presence of left bundle branch block or right bundle branch block. So it's easy. This is important before, but after, when you have to ask for another EKG. So our protocol is 24 hours, not more than 24 hours when there are symptoms. What kind of symptoms? Fainting, dizziness, syncope, sudden death, in the presence of sudden death submitted to successful reanimation, resuscitation. If you find a patient with prolonged QT interval and these symptoms are still present, there's a lot of things to do, correct magnesium, potassium, take off medications that prolong QT, and 24 hours repeat. And repeat every 24 hours until the QT interval is under more friendly situation. That's the first thing. In patients without symptoms, but with prolonged QT interval, this interval can be bigger. And it can be weekly, once a week. There are no symptoms, but the patient has prolonged QT interval, and there's important medication that must be maintained because of your psychiatry problems. Okay, no problem, but once a week, let's repeat the electrocardiogram. And finally, I would like to comment what we have been doing. I have another bias, conflict of interest, is that because I'm deeply involved in arrhythmias related to one stupid form of treatment for COVID-19, which is hydroxychloroquine. There's a confusion that everybody in the world does not use hydroxychloroquine for COVID-19. But there's one person in Brazil that it's our president that still, even Trump doesn't like hydroxychloroquine, but Bolsonaro does. And this is important to say because there are several physicians in Brazil that are confident with hydroxychloroquine. And we have been studying, we have an approved grant from the Brazilian Federal Agency just for looking for QT interval prolongation with hydroxychloroquine. And we are studying three methods. The method that Scott mentioned, the simple calculation with hydroxychloroquine, and also azithromycin, another drug that prolongs QT. And we have been doing two other methods. And this maybe Scott is not familiar. One of this is in collaboration with Professor Richard Verrier from Harvard. He is at the Deaconess Hospital in Harvard. And he has a software that calculates not only the simple measurement, but also the amplitude. Because the variation of the amplitude, the measurement of the amplitude of the QT is a stronger predictor of torsade point and cardiac death. And there's another hardware that it was developed by a Brazilian company called TEB, T-E-B, that calculates not the highest, the amplitude, but the measurements of the duration that also varies according to not only heart rate, but also medication and more, even more importantly, autonomic status. So we are studying this system in COVID-19, but we are planning to study this in other situations like psychiatric drugs, and I'm inviting you and Scott and Marina to do this maybe in another future collaboration project. That's all. Thank you again. And Scott, it was a pleasure to hear from you.
Thank you, Professor. We have some questions from the audience. Can I read it? Do you want to talk a little bit more? I don't know.
That would be fine with me. Go ahead and
Okay.
let's do the questions.
So we have a lot of people saying thanks and congratulating you for the lecture, and some questions here. So the first question is, how can we manage patients that are on chemotherapy with risk of Qt prolongation at the same time with antidepressant and ondansetron, since ondansetron and some chemotherapies also prolong Qt?
So great question, a really common situation that we run into. And, I think in all situations where you have other medications that may prolong the Qt or other risk factors, it really just comes down to doing kind of an individual risk-benefit analysis for that patient. And so making sure that you know what the QTc is when you're starting the psychiatric medication, and really kind of weighing the risk and benefits. If it's someone who is, a little bit depressed and you want to start an SSRI, then you might start an SSRI that carries lower risk. Or you might say, you know what, there's probably not going to be a huge benefit to starting this SSRI today because we know that it's going to take 4 to 6 weeks to take effect, and they're going to be off of the ondansetron in another couple of weeks. So maybe we delay the start of the SSRI until things are a little bit safer. Whereas, somebody who's wildly agitated and at risk for ripping out their port because they're delirious, that's a situation where you say, you know what, the risk of not giving that person a medication is quite high. And so we're going to choose a safe agent or a safer agent, but we're going to sort of monitor closely for Qt prolongation with that.
Thank you. And some other questions here as well. So one of our professors, André Mabéger, that studies drug abuse, he's asking if drugs of abuse like alcohol, cocaine, tobacco, or cannabis increase the risk of Qt prolongation in patients using antidepressants or antipsychotics?
My understanding is that among drugs of abuse, the ones that have been associated with Qt prolongation are alcohol and cocaine. But I have to confess that I've never actually seen the evidence for that. I've just seen that passed along in a list of risk factors. Dr. Caramelli, do you know any specific evidence, or are there other drugs that are at risk?
Yes, I have heard about it, but no publications, no data, no conclusive data. So I should say that the most important than everything is to not avoid to use before, but check by a simple EKG later on, eventually.
Nice. And another one is, do you think that the platforms such as UpToDate are reliable in terms of information regarding drug interactions and Qtc prolongation?
I think they're a really good starting point. So I think that they are generally pretty good in terms of drug interactions. I think the challenge with Qt prolongation is, especially in the past decade with regards to psychiatric medications, it's a pretty rapidly changing field. And so despite its name, UpToDate may not be so up to date in terms of the latest, because it only typically gets updated every couple of years. But I would say it's a great starting point for those issues. And there aren't better resources that I would recommend except going directly to the literature. And so I think it's a very good place to start.
And the last one is from one of our residents. He's asking, because you told us about haloperidol, like IV and the oral use, but he's asking if there's any study or evidence for the use of like aldol decanate.
So when we did our review, we really focused on intravenous. What we saw for there was one study for intramuscular form in general, but it was the short-acting intramuscular. I did not come across anything specifically with the decanoate form. I don't know if anybody else has seen literature on that, but I didn't find anything in the review. And Dr. Caramelli, I just want to say that your comment about haloperidol is probably the least surprising comment to me, because it mirrors that of every cardiologist I've ever spoken to about haloperidol.
Professor Lee, I don't know if you want to talk something, but we have also here Professor Saleh, who is our residency coordinator. He just entered to get to know you, Professor Beach.
Wonderful. Nice to see you.
Hello. I'm very proud to know you, Dr. Beach, and I, as has told Marina, we work with the coordination of the residence program here at the Institute of Psychiatry. And if you permit, I would like to kidnap you a little bit in order to talk about, I have read some papers your group has been publishing concerning a huge revision of this residency psychiatric program at the MGH in McLean. And we would like very much to hear from you what kind of experience you have had concerning this change in the curriculum, and also what kind of recommendation you could give us in order to implement a more balanced curricula in our program.
Absolutely. I'd be happy to talk a little bit about that. So when I, about 8 years ago, I became the associate program director for the residency, and my mentor, Felicia Smith, who was program director at the time, said, I'm going to give you this really big project to do, and this is going to be kind of the thing you do for the first 2 years. And she said, all of our seminars that we have throughout the residency are not, a lot of them are not very well reviewed, so the residents don't find them particularly useful. We have this problem where we have all these experts across the system, but they're only coming by to give one talk, and then the residents never see them again. And the seminars are not really coordinated. So, you know, they're sort of a random assortment throughout the 4 years. So we want to kind of overhaul everything, and we want to create a really structured and organized curriculum that flows from year to year, and that has seminars organized into larger chunks so that they kind of make sense to the residents in terms of when they're getting it. So it was a big project, but the way we decided to tackle it was we came up with a list of about 20 broad topics that we thought were really essential to residency training. So they were things like psychotic disorders, consultation liaison psychiatry, psychodynamic psychotherapy, administrative psychiatry, 20 or so of those. And for each topic, we identified 2 faculty members who had expertise in that area, and 1 or 2 residents who had an interest in that area. And we said to them, okay, you're the working group for this topic, and we want you to identify or to come up with sort of an ideal curriculum for your topic. And we also went through all of the hours of seminars that the residents were currently getting. It turned out that residents were in seminar for 764 hours throughout their 4 years of residency. So there were a lot of seminars. And we went through all of those, and we divided them up into the 20 topics. And we gave the work groups the list of the current seminars that were in their topic. And we said, okay, design your curriculum, and of these seminars that are already in your topic, tell us what's missing, what doesn't need to be there, what faculty are good teachers, what faculty should be added as teachers, and kind of design that as you would. And so we got these 20 different curriculum, and then we had a central group that had the hard, of course, everybody wanted more time, right? So everybody's recommendation was, well, we should be given more hours to teach our topic. And so we had a central group that was then tasked with trying to figure out, okay, who was going to get what time and in which years of residency. And we essentially worked to kind of mold all those work group recommendations into one curriculum that would last throughout the 4 years. So that was kind of the process, but it was obviously challenging in a lot of ways, but also really fun to kind of take a huge perspective on the curriculum like that.
Okay. Yeah, I have read you have begun in 2012 with this project.
Yes.
Now, probably you are trying to do some evaluations
yes.
of the results.
That's exactly right. So we launched the first version of the new curriculum in about 2016. And then subsequent to that, we've just kind of been updating it a little bit each year, but we've been collecting for every hour that residents are in seminar, they get a survey. It's a very brief survey, but that's how they log their attendance. And then we also ask them to give feedback on that seminar. And so we have evaluations for all of the seminars over the past 4 years as well.
Really nice job. Congratulations.
Thank you.
We have thought about the possibility to have a symposium maybe in the next year in order maybe to discuss these issues. And we could, if you are available, we would like to invite you to give us some advice concerning this huge project. Thank you.
That would be wonderful. I'd be happy to do that. Thank you.
Thank you. So Reid, you want to make a closing comment?
Thanks a lot, Adrian. Even happier to see you talking to our chief resident here and making plans for the future, making our institutions closer. So I couldn't be happier about that. And I was also enchanted with your talk, but not surprised by how deep you went when talking about this interface between psychiatry and cardiology. I always was very impressed when I did my training at MGA and get in touch with the people at the consultation liaison psychiatry there, of how much they were prepared or how much they still keep their medical education in their work as a psychiatrist in the consultation liaison service. And I'm also very happy that we invite Bruno Caramelli. Couldn't be a better person to make the comment here. I didn't know, Bruno, how deep you are on the psychiatric medication and in this kind of problems that we encounter with our patients. Scott, I'm here now. I specialize in OCD, so I work a lot in OCD, and as you know, we use SSRIs in a higher dose on those cases. And I had already an experience with citalopram when the black box of a warning came up from the FDA. And I was a little surprised because although I had already treated a lot of patients with 80 milligrams of citalopram and I never had any problem. So since then, I started to lower the dose and follow the Qt interval in some patients. And also with citalopram, which I went sometimes to 6 milligram, I started to be more cautiously. But as you know, in OCD, we need to go further in some cases. So I am using higher dose on those patients, following with some EKG. And my question is, as I learned here with you and Bruno, probably should do if I get to 40 milligrams and I want to go up, I should do an EKG. And then my question is how frequent I should do the EKG if I went further to 8 milligrams, for instance.
I think that's the big question. I'm really curious to hear what Dr. Caramelli recommends, because in the US, there's really no good consensus on how to monitor that from there.
Actually, I learned from you. I was not aware of this debate regarding 20 and 40 milligrams. But I always advise my consultees, and when even in the university and out of the university, to each increment in the dose should be before increasing the dosage, to get an EKG and take a look. There's some kind of cornerstone or principle, golden principle for interconsultation between specialties, that try the best you can not to modify the way they treat their patients. Even if I declare that I don't like IV haloperidol, if you tell me that that's important, okay, I believe you. I will do my best to mitigate the effect of this adverse effects. So if you tell me that 40 milligrams, it will be better for your patient, I'll try to do my best to mitigate the complication. That's I have this in my, in a picture in my office wall.
And Dr. Caramelli, if somebody was on, say, 60 milligrams of citalopram, or a medication that is considered high risk, and you've checked an EKG before going up, and then maybe you've checked an EKG, a month after you go up, if nothing changes, do you think there's any reason to check another EKG in 6 months or a year?
No, you don't have to change unless there are some other conditions. If the patient had a heart attack, myocardial infarction, starts using diuretics, yes, then you have to check again. That's important. I just to get a couple of months ago, I get a patient that lived in the United States that was taking 450 milligrams of Wellbutrin. I didn't know that this was an allowed dosage. It's on Hippocrates is the biggest dose, allowed dose. And the patient was having adverse effects. What kind of adverse effect? Tachycardia, which is comprehensible. And I have to struggle myself to contain myself, because there were indications that this dosage was needed to that patient. So that patient, now she's living in Brazil, and she went to different psychiatrists to try to use a different drug. But it seems that another drug can be okay for her.
I have to say, I'm really impressed with what you talked about in terms of the use of technology to calculate and to monitor. You guys are way ahead of us in terms of that. We're still, even internal medicine residents and cardiology fellows are still calculating things by hand. So I'm going to have to get up to date on some of these apps.
Send your students or residents to Richard Verrier or to...
Great.
Thank you so much, Leo, for the presence, and thank you, Professor Beach. Thank you, Professor Caramelli, for the presence, and thank you, Professor Saleh, for the late call. I don't know if Professor Ali wants to make some final comments.
In the name of our department, again, Scott, I appreciate a lot you being here with us, and hope this is the first of several.
Agree. Thank you so much for having me. This was really fun.
Bye-bye.
Thank you so much. And just to finish in Portuguese, muito obrigada a todos pela presença. Na semana que vem a gente vai ter Viviane Silveira, uma artista plástica, falando sobre o trabalho dela com pacientes com estresse pós-traumático, e os comentários do professor Dr. Felipe Cox. E muito obrigada, assine nosso canal e nos vemos na próxima semana. Thank you all. Bye.
Thanks everyone.